Mr. Mike.
How you doing?
Good. Your Tesla didn't catch fire yet, did it?
Yeah,
It wasn't on. It was just on
Yeah. Oh, man.
Well, it was not my house, yeah. No, I remember when these kids were in high school, it happened inside of our house. It's a cleanup.
My buddies have been stories.
It does melt in the rain.
If you say so.
Don't tell me how they test that.
Especially if they're good at getting by trees or something, you can't get it.
You do? Yeah.
Shirt and jacket because I want it.
That's what $60,000 jacket.
It was worth it.
Cars, you got really sick of those.
You like it?
I love it, yeah.
They build some charging like thoroughfare, like you go across the country.
See, that's the thing, and they're putting in free charging stations, and they've already got a bunch of them on the website. So you go plug in and they're free. It's fast chargers, like they have one in
Although you've had
Chehalis, there
more
are 10 stations, there's one in Burlington, and they're free. Yeah.
So you've never
The ones that Stevens aren't free, those aren't free.
Oh, you have to have a specific one, so you can't use any.
Well, you can use some, you have to have an adapter. They have them at Walgreens, that you can use your adapter to. So they're getting more and more.
a lot easier.
So you never have to pay for gas. Or
I'm
anything.
never gonna pay for gas again.
They're gonna start charging mileage, you know. They're gonna do that.
Yeah, that's the next thing I'm gonna be taxed for using the highway.
Yeah, that's
And your car's so heavy, they'll give you the road use. Just those electric motors, they weigh a lot. All of us are just chills, that's what you know. See, that's,
I can set you up with a guy who'll sign one.
What do you think of the
walk around the
SUV?
My
car.
son works for him.
Oh, is that right?
Sun sells to-
Did you buy it? So did you buy it from him?
No, I put my money down before he got the job.
Oh, all right.
It was a couple years ago, I was visiting one of their showrooms in Santa Clara. And they have a showroom just like that in Bellevue, this little storefront. You know? I said, what's this car? I said, where are these? In a couple more years. They said, ship it money, I'll put your money down. Get in line.
Watched the game last night.
Well, I saw where Baldwin's got one on Bremerton. He wouldn't come to it for a long time, and finally he said, yeah, I got one of those things.
Well, and I can't believe it didn't come.
Apparently they're really selling a lot in Finland.
Yeah, and I was thinking that if you have actually 10:30 flight.
What do you think of the new SUV?
Just looking forward to it.
Oh,
I had to assess with the car. Like,
oh, is that right?
how do you like it?
I didn't even know it was out.
It's not out yet. So put your money out like you just said. But this is where my husband's obsession is. He's like, can you find that one?
Did you go on the website?
Oh yeah. Oh yeah. Or I show it to you guys and it shows it to me daily.
Well, it's four-wheel drive.
I got an
and
email
guess
yesterday
it's
from
not
Alice
as
Wheeler.
expensive as
Okay.
No, it's in the
four-wheel drive, did you say?
60, yeah, 40, 60 plus.
So you say four-wheel drive?
Yeah.
No, then I'd have to look.
And it looks more like a car, so it's not a big
This
huge
looks like a car.
No, mine's not four-wheel drive.
It is a car. Yours is a car.
Sedan.
Thank you for answering my questions and overhearing the conversation. He is
Yeah, I was-
seriously obsessed.
I was trying to do it via my iPad. I didn't try it with my computer, but there was some
It's a good investment.
Silverlight app.
Just put the battle armor underneath so the road rash can't come out and blow up your car.
Computer to do it, and I'm sure there's a problem.
Make sure you're not picture a lot.
Watch it later.
Good.
Ryan sent a nice letter about such a improbable thing that didn't work. Yes, car would.
Dr. Corren.
It's just interesting to see the picture of this huge fireball. Used to be a test. It's like,
Got the official shirt color. That's right. You got an orange tie. I got Halloween.
Because I wasn't invited.
No, I
Ellen said he's going to have a December 2nd.
I don't know.
I believe it. I know every year. Are you going to be a female? Andrew? You just female person.
You should try and cover it out.
you out of your?
I had
out
it.
of your hotel?
Someone's got to be voicing.
Is he get
All right.
So I'm downtown.
Thank you for my email, Steve.
Hey man, can be that was a good Yes. Yeah, so I cover basically all places.
When you're driving your car around, so weird people out there, they can't hear you. Turn around, literally.
Do you want to eat it that way?
Don't want to hear it. He just sort of waved at us as he nudged us through the intersection.
10 to 15.
It's a lotus. Yeah, it's a lotus body.
Sweet too.
It looks like something that would be on the racetrack. They're eroding all our parking, Drew. They took these 2 spaces away now.
You read that closely, and it looks like you shouldn't be parking.
Tow-away zone all other time.
I read that a couple times. Now I don't park.
Yeah. I'm in front of you. Well, there's another car in front of you, and I'm in front of them. But that was a good space before.
7 o'clock, Drew?
Yep.
Okay, let's go ahead and get started. Jonathan Corren's our guest speaker today. He's from UCLA, although he flew in from the chess meeting in Chicago and got in late last night. I titled this something like Cytokine Therapy for Asthma, but he's broadened it, I think, to new directions or novel new therapies for asthma. And then remember, the sign-in is now electronic, so the word you have to remember is cytokines to sign in for CME credit. And then we'll take a brief break and go ahead and present him an asthma case, although he's got a fairly close airport connection, so we'll try and wrap up the day about 8:35, 8:40 or so we can get him out to the airport. Jonathan?
Excellent. Thank you all for coming this morning. It's early for all of us, so I appreciate your presence. And I will say that in respect to the theory of relativity, this still is warm compared to Chicago. So I'm glad to be here. Something that I've worked on over the past 15 years has been developing new therapies for asthma. Many of you in this room engage in the same kind of work. And it goes back many, many years. We're going to talk about some of the early work with cytokine inhibitors and focus more so on the things that are becoming very relevant to our practices in the near future. And these are my disclosures. I work with a number of companies that are developing new therapies, as you can see. And what I'm going to talk about first are cytokines and their inhibition and how they're going to be relevant to our practices. The last couple of years has seen an explosion of data in this regard. Talk a little bit about prostaglandin D2 antagonists, although there's not a lot of data available. I think this is going to be an important therapy that we're going to be using in our practices in the next couple of years. And finally, moving into something that's just on the brink of being developed, which are toll-like receptor 9 agonists. So we'll start with cytokine inhibitors. There are a number of cytokines involved in pathogenesis of asthma, as well as the other allergic diseases. And going back to the late 1980s when Immunex, which is one of your neighbors, was developing a soluble receptor, And we'll talk about that a little bit. And over the ensuing years, Interleukin-5 was designated a target. And then very recently, some things are just starting to emerge as potential targets. And I'm going to share with you things that are just in abstract form, have not yet been published in full-length peer-reviewed articles. But I think will give us an idea of how vast and broad these potential targets are going to be. So we'll start with Interleukin-4 and 13. What I want to do as we move into each of these areas, talk about what these cytokines actually do, and talk about how they're going to be relevant to treating these diseases. Now, I would call IL-4 and IL-13 the evil twins of allergy from the perspective that they share most of their effects, with the exception that IL-4 does cause differentiation of naive T cells into Th2 cells. The principal cellular sources for IL-4 and IL-13 are Th2 lymphocytes and mast cells, and to a lesser extent some other cells. And what I think is very important to recognize about these two, and I think the largest amount of work is going to be focusing on IL-13 rather than IL-4, is that they really act locally in the airway. When you attempt to measure concentrations of these two cytokines in the bloodstream, you don't come up with much, in contradistinction to Interleukin-5, which I think can be characterized as more of a hormone that directly affects bone marrow. And since IL-13 administration in some animal models go all the way back into the 1990s, the administration reproduces many of the signs of asthma. Not just eosinophilia, which we'll see with Interleukin-5, but many of the signs such as smooth muscle hyperplasia and basement membrane thickening. It's been termed the central mediator of asthma. And I think that in many ways we may find this to be the case based on some recent studies. So if we look at some of the specific activities of IL-4 and IL-13, they're very vast, they're broad, and I think they're all very relevant to what we see in the clinical picture of asthma. One of the things that they're important in doing is eosinophil adhesion to the vascular endothelium. They cause mast cell proliferation and activation. And I think very, very importantly, they act on the epithelium. And this is what we're recognizing as a very prime target in the early stages of both sensitization and the development of inflammatory airways disease. There's an increase in permeability. There's an increase in goblet cell differentiation and growth. And when you look at goblet cells, you start to think about the phenomenon known as airway remodeling, where goblet cell growth is one of the prime activities that takes place. And this is something certainly that glucocorticoids do not have a large effect of. They lead to fibroblast activation and collagen synthesis. And here again is one of the primary processes that we find in airway remodeling. And although this has been carefully looked at with respect to inhaled corticosteroids, there are small effects, but of questionable clinical relevance. And GlaxoSmithKline spent a considerable amount of time looking at biopsy specimens from real patients who had asthma and found that you could pick up very small statistically significant reductions in collagen synthesis taken from the basement membrane of patients with asthma, but it didn't amount to anything that they would consider to be really clinically meaningful. There's an increase in smooth muscle contractility. This becomes a very relevant point because it may lead into how fast an onset of action an IL-4 or an IL-13 inhibitor might in fact have. And then finally, we come to what I think we as allergists may be considered the most important activity of these cytokines, which is they lead to an isotype switch from IgM on B cells to IgE. And certainly this is something that's critical. Yes, Len?
I don't want you to digress too much, but in listening to this, I wonder, obviously we have these cytokines for a valuable reason, and people study this, so this whole list is what they do bad in asthma or other disease. Anybody studied them in normal biology as to what they do in a health-directed way, in parasitic infection or what have you?
Well, I mean, certainly this part of the immune system is directed towards the prevention of parasites. And there has been work that's been conducted in the last decade looking at if you get rid of IgE in a population in Latin America, will it affect health? And I think in the same regard, what you're going to be basically doing is limiting the efficacy of the eosinophil arm of immunity as well as IgE at the end of the day. And in places, I think, where you have endemic parasitosis, it may be an issue. It may not be something that we'll recognize in a small study, which has been done, for instance, with Mepolizumab, where they've got some limited data looking at its use out of the United States. And it may be something that comes up when people who are on these drugs inadvertently, travel to Southeast Asia, and then we see, rampant parasitic infections. But I think for the time being, at least in Western societies, we're hoping that we can get along without this.
but I think your question is very well taken. The receptors for these particular cytokines are important, and the reason they're important is because there's duplicity in the way this whole system has come to the surface. If we look at the cell surface membrane and we look at the IL-4 receptor, IL-4 shown with a yellow dot, we can see that there's a gamma chain up against the IL-4 receptor alpha. And these two proteins together constitute the IL-4 receptor. If we now look at the IL-13 receptor, what we find is that, again, you have the IL-4 receptor alpha paired now with the IL-13 receptor alpha-1 chain. And these are shown butted up against activation proteins that get translocated to the nucleus and allow promoter sequences to be transcribed. So what's interesting is, therefore, and this was an approach that was taken many years ago by Immunex when they designed a soluble IL-4 receptor, which would bind to the IL-4 receptor alpha chain and thereby act the IL-4 receptor alpha chain acted as essentially a decoy for IL-4 in the system, as well as IL-13, because that's the common chain between these two receptors, and used either as a decoy or if you had an anti-receptor antibody, you would achieve the same goal, which is to block both of these cytokines by knocking out one of these chains. So hopefully that is, I think, very clear to everybody. And what's interesting is you also have an autoregulatory receptor. And in this case, you don't employ the IL-4 receptor alpha chain, which is very important in transducing the signal into the cytoplasm, but rather you've got an IL-13 receptor alpha-2 chain all by itself, which is able to bind IL-13 and doesn't cause any kind of a signal transduction. And it's been thought that this may be a decoy, which in some ways allows IL-13 in excess to be blocked endogenously by the body. Now, there have been a number of approaches that people have taken going back into the late 1990s, starting with, as I've mentioned before, the soluble IL-4, IL-13 receptor. In early studies, it was demonstrated that there was a steroid-sparing effect of this molecule in patients with severe asthma. But at that time, I don't think we fully understood the importance of asthma phenotyping. And when the program was switched to looking at mild beta agonist-only patients, what they were able to determine is that there was no effect at that time. And in all likelihood, there may have been either no excess in IL-4 or IL-13. These may not have been candidates, as we would now recognize by phenotypic signs and signals, things like periostin, nitric oxide, blood eosinophils or sputum eosinophils certainly weren't determined back in those studies, and the program was essentially abandoned. There may have been other issues as well, such as how efficacious was the molecule when you give it as a soluble aerosol. How is the duration of the drug once it's inhaled? These sorts of factors I don't think were fully answered. So some other work followed that. There was an IL-13 mutein called Pitrakinra, made by Aerovance, which did show efficacy in an antigen challenge model, with suggestions that patients who were genetically upregulated to produce IL-13 may have had an enhanced effect. This was published upon, but for unknown reasons, this drug did not continue in development. And some of you may know the answer to that better than me. So we've come now to an era where over the past few years, there have been a number of antibody candidates that bind directly to IL-13 and or IL-4. In the case of, and that's with respect to the receptor antibody, but with respect to using the cytokine itself as the target, Lebrikizumab, made by Genentech, and Tralokinumab, made by MedImmune, have both released some early phase proof of concept data which suggest that in fact there is biologic activity, which has not yet been well defined, and I think it remains to be seen how efficacious these drugs will be in native asthma. And then finally, the most recently published upon target, which is an antibody to IL-4, IL-13 receptor, targeting the IL-4 receptor alpha, which is a drug called Dupilumab, produced by Sanofi. So what we're now going to do, it's going to, I think, some of the more recent data that's tried to illuminate this concept of whether you bind to IL-13 by itself or bind to the receptor, whether you can actually have any efficacy in treating the disease. So we're going to go to a study that was published a couple of years ago. I'm familiar with it. I was one of the authors. and it's Lebrikizumab, which was tested in a proof of concept study, a relatively small proof of concept study, in patients with poorly controlled asthma. Some of the things to keep in mind is that this is a humanized antibody, very much like Mepolizumab. It's not a fully human antibody, which contrasts with some of the other candidate antibodies that are in development. In this particular study, it was a symptomatic population. They were all taking approximately 1,000 micrograms of inhaled steroids per day, and 80% of the population entered into the study was taking a long-acting beta agonist. So it's a study that certainly looks at the patients in our practices who are not fully responsive to what we would consider to be near optimal therapy. Patients were then randomized to a monthly dose of Lebrikizumab. The dose chosen was 250 milligrams, which at the time was thought to be one of the higher tolerated doses. It was compared with placebo over a period of about 6 months. Importantly, and this is again what contrasts with other studies, baseline therapy was maintained. So if they came in at 1,000 micrograms of fluticasone, they stayed on it with no attempt to taper the drug during the study. Now, interestingly, they had data suggesting that from Prescott Woodruff down at UC San Francisco, that patients who had elevated levels of cytokines, particularly Th2 cytokines, would be the target population for this drug. So the question would be, how do you identify who has an elevated IL-13 or just as relevantly an elevated IL-4? And what they discovered were that there were proteins produced by the epithelium, one of them being periostin, that was upregulated directly by IL-13. Another target for upregulation by IL-13 turns out to be exhaled nitric oxide. So both of these end up being very good surrogate markers for a cytokine that is extremely difficult to measure unless you induce sputum, because you're not going to pick it up in the bloodstream. Now, they didn't have a periostin assay completely perfected by the time this study was launched. So what they did was they came up with a surrogate based on data from Dr. Woodruff suggesting that both periostin in concert with blood IgE and blood eosinophils could potentially act as a good surrogate marker, what they called a high or a low Th2 signature, which would be employed to randomize these patients and act as a stratification factor. By the end of the study, they had worked out the periostin assay, so in a post hoc fashion, they were able to go back, and it turned out that the people who were high Th2, with a high IgE above 100 and a high blood eos above 140 cells per microliter, ended up, in most cases, being the patients who had an elevated periostin. So they ended up with pretty good numbers of patients randomized in both active therapy and a placebo. And in this study, they targeted FEV1 as the primary endpoint, not exacerbations, not symptoms, not asthma control. I'm going to stop right there and see if there are any questions. I don't know if the people who are remote can speak into a microphone, right? About this particular study design. Okay. And what we'll look at is the FEV1 data. In the top slide, we're looking at the total cohort. And Lebrikizumab is marked by the dark diamonds, sample size of about 106. Thanks, Len. So we're looking at Lebrikizumab and we're looking at placebo with the open white squares, a sample size of 112. Now, understanding that this drug might be very phenotype specific, they then looked at patients who had a high periostin. What they used for the cutoff of periostin was the median for this group. In other words, a somewhat arbitrary measure, but they didn't have much else to go on because they didn't understand really what the distribution of periostin would be in a very severe population. All they had really at that time was data from mild to moderate asthmatics. And what you now find is really an expansion of the effect, or an enhancement of the effect. That now you see Lebrikizumab in dark, and you see the placebo in white. And we find that what was statistically significant but of questionable relevance starts to become a much more pronounced difference. And if we then conversely look at the patients who had the periostin levels below the median for this group of patients, we find that there's essentially no difference at all. And this was a unique finding demonstrating that the implied presence of interleukin 13 as measured by periostin, or you could say to some extent by IgE and eosinophils, ended up becoming a very important determining factor in how patients responded to this drug. If we look at other endpoints, we find that there are really no other. Yes?
What cells produce the periostin? What's the main?
Epithelium.
Epithelium.
Yes. So both periostin and nitric oxide are synthesized by the epithelium. People often think of nitric oxide as a marker of eosinophil function or number, but in fact it correlates with eosinophilia, but it's not produced by eosinophils. So really what it is, better than anything in the case of nitric oxide, is a marker for residual IL-13 activity in the airway as produced by the epithelium. So when we look at other endpoints, exacerbations, asthma control, and asthma symptom scores, we find that there were no differences. Now I have to couch these comments to a certain extent. The asthma control questionnaire, as developed by Elizabeth Juniper, was validated in patients with mild to moderate asthma. And the results of that cannot necessarily be implied that it will be a sensitive test at detecting differences in people with more severe asthma. So I think finding a good instrument in patients who are, in fact, requiring large doses of inhaled steroids or oral steroids and still not responsive could potentially require another instrument. This has been discussed. Interestingly, with regard to exacerbations, we see a small difference. When patients were stratified, the analysis was based on nitric oxide level, high and low. Using the median as the cutoff, there was a statistically significant difference between Lebrikizumab and placebo. So there may be certainly some activity on exacerbations with respect to this drug. Steve?
The inclusion criteria didn't require an exacerbation in the previous 6 months.
That is correct.
So
these are people with severe asthma.
Are more looking for more volatile. So I assume they're hoping.
Right, and I'm glad you brought that up, because certainly we think exacerbations, particularly when you get to 2 or more per year, becomes an individual phenotype. There was recently an article written, which is going to be appearing in Clinical Experimental Allergy, where they really see pathophysiologic differences. They didn't get down to genetics, but at least pathophysiologically, the people who have exacerbations 2 or more times per year in the previous year have a much higher level of sputum eosinophil than the people who have 1 or less exacerbations. So that is a phenotype you really have to look for. And in this case, it turned out that many of the people had an exacerbation, but it was not a qualifying criterion to be in the study. Any other questions about this? Okay. So a different approach, and people have postulated could be better or could be worse, would be to try to block the effects of IL-4 and 13 in this case by binding to the receptor itself. In the case of this particular molecule, Dupilumab, which is an anti-IL-4, IL-13 receptor antibody, it's a fully human antibody. It was produced through Regeneron's technology and is now being put through clinical development by Sanofi. And it's a very similar population as to that which was studied with Lebrikizumab, poorly controlled asthmatics. All of the patients were on high-dose inhaled steroid. All of them were on long-acting beta agonists. And they all had to have had a prior exacerbation during the preceding year. So in this way, it does differ somewhat from the Lebrikizumab study. And you'll notice that the dosing is extremely different. Whereas you have 250 milligrams of the anti-cytokine antibody, here you have 300 milligrams being given subcutaneously every single week. Okay? But you can't compare these doses any more than you can compare apples and oranges because of what they're really targeting. To get saturation of the system, these are the doses that were determined to be given. And this was thought to be the highest tolerated dose. The stratification in this study was based on blood eosinophils, either high or low. And in this case, they came up with an actual recommendation that it would be 300 cells above or below to differentiate the 2 groups. Keeping in mind that blood eosinophils certainly are a marker of IL-5. Are they also a marker for IL-13? To the extent that IL-5, IL-4, and IL-13 tend to move in the same circles, they tend to come from the same clone of T cells, and there's about a 60% correspondence between IL-13 and IL-5, but not 100%. So this leads us to the idea that, in fact, in the future, there will be candidates for anti-IL-5 drugs and anti-IL-13 drugs. And it was an inhaled steroid tapering study design, very different from what we normally see. The LABA was stopped after 4 weeks, and the ICS was tapered over a period of 4 to 8 weeks. So you might consider this to be a very gutsy attempt to prove a drug is effective, in essence, withdrawing all therapy over a period of about 12 weeks. Now, this is a little more difficult to see, but let's turn first to the lower left. And what we're looking at are both absolute FEV1s, shown in the lower curve, and FEV1 as a percentage of predicted. And we're looking at Dupilumab in blue and placebo in red. And what we're seeing is a differentiation between the two that occurs fairly early on. We start to see separation at about a week, and by 2 weeks, these two are statistically significantly different. The reason we do see, at least with Tralokinumab, with Lebrikizumab, and now with Dupilumab, fairly rapid onset of action. Can't tell you if it occurs in days, but certainly in the first week, we're starting to see activity. And it's postulated that this is probably the effect of inhibiting the activity of IL-13 and potentially IL-4 on smooth muscle contractility. So you're starting to see actually a sort of bronchodilator effect, you might call it, by blocking this effect of IL-13 on smooth muscle. So throughout this effect, and even after, if we look to see when LABA was withdrawn here, and where inhaled steroids were tapered here, and here you have Dupilumab all by itself, FEV1 was essentially maintained. If we now look right above that at the exacerbation data, we find a marked reduction in exacerbations comparing placebo to the active drug, keeping in mind that we're really aggravating the tendency to have an exacerbation by pulling away all inhaled steroid therapy. And then finally, as we move directly across from that, we look at a Kaplan-Meier curve. And in fact, even before the withdrawal of inhaled steroids, we do see in this section of the study that the exacerbations start to increase in patients getting placebo simply by withdrawing the long-acting beta agonists. And we do know that long-acting beta agonists, at least in some studies, have an effect on downregulating and modulating the occurrence of exacerbations. And then finally,
They pulled away the drugs independent. There was no endpoint that people had to meet. They just pulled them away no matter how they were doing in the study.
they were destabilized. In fact, yeah, if they were stable, they were withdrawn. If they were unstable, they were withdrawn. If they became unstable enough, they were pulled out of the study. And so you really have is an analysis that, to a large degree, includes the last observation carried forward because of the dropout rate in the placebo arm of the study. So we've got a couple of interesting studies sort of on our plate. One that inhibits both IL-4 and IL-13, which may end up being an advantage because of the effects on differentiating naive TH cells. We've got the other drug, which only inhibits the effect of IL-13. They appear to be most effective in patients who have active Th2 inflammation. This makes sense because despite the use of inhaled steroids, there may be residual activity of these cytokines. Anti-IL-13 antibodies seem to have a salutary effect on pulmonary function, but not much else at this point. Whereas the most recent data using the Dupilumab seem to have an effect not only on pulmonary function, but a fairly large effect on exacerbations. Although if you read the editorial by Michael Wexler in the New England Journal of Medicine, the point that he makes is, in real life, we don't withdraw inhaled corticosteroids unless patients do it on their own, as we have seen plenty of times in patients that are successfully treated with Mepolizumab. Now, Interleukin-5 certainly is the cytokine predecessor of what we've already seen. It was an earlier target. It was heavily investigated during the 1990s. A number of companies were working on the inhibition of this cytokine. The main cellular source, as we know, comes from Th2 lymphocytes, but as well from eosinophils and basophils, to a lesser extent some other cells. Large amounts of this are measurable in the systemic circulation. So you could almost look at this as an eosinophilic hormone. The main effects are to increase the number of progenitor and mature eosinophils, as well as basophils, not only in the blood, but together with IL-4 and 13, entry into the bronchial tissue as well as other target organs. And in this case, we're discussing asthma. Along with this, an increase in eosinophil activation and eosinophil survival. So if eosinophils were the largest and most important contributor to asthma, then this drug by itself should have a tremendous impact on clinical symptoms and exacerbations of asthma. But keep in mind that IL-5 unto itself does not have many other effects, either on resident cells or inflammatory cells that ingress into the airway. A number of molecular approaches have been developed. Antibodies directly against interleukin-5, Mepolizumab from Glaxo, and Reslizumab in development from Teva. There is an anti-IL-5 receptor antibody, in this case produced by MedImmune in the form of Benralizumab. There are antisense oligonucleotides that try to fool the DNA and RNA into producing either proteins that are not actually IL-5, or ineffective precursors, or prevent transcription completely. And then there are small interfering RNA fragments, which is a newer technology that is just on the cusp of investigation. Let's go back many years, and if you look at this slide, it's dated 2000. It was a publication in Lancet, where this was to be a demonstration that, in fact, IL-5 played an instrumental role not only in the eosinophilia of asthma, but in the pathogenesis of asthma. So they used a standard antigen challenge model, patients with very mild allergic asthma. In this case, 2 different doses of Mepolizumab were given. Small sample size, relatively speaking, but enough to at least get an idea, approximately 8 patients per group. And an antigen challenge was performed before and then 8 and 30 days after these drugs were administered. And what we're looking at in this graph, right next to this description, is the baseline eosinophilia going up and down. And this certainly is characteristic of blood eosinophils, that they do go up and down, not only from day to day, but in fact from morning to afternoon to night. And then if we look at the effect of the low and the high dose of anti-IL-5, we find a profound reduction as we go through the weeks of this study, reaching a nadir out at around 30 days after the dose. That in fact demonstrates that this drug is able to deplete eosinophils from the bloodstream successfully. One of the questions became, did it actually deplete from the bronchial tissue? So we answer this question by looking at the additional effects of anti-IL-5 in an allergen challenge model, where we find that there was a 93% reduction in sputum eosinophils. So far, so good. But there were no changes in the FEV1 late phase response to allergen, and I may as well mention, nor in the early phase. And there was no change in nonspecific bronchial hyperresponsiveness, which was induced by the antigen challenge. So the conclusions at that time were that IL-5 certainly mediates the eosinophilia that we find both in blood and sputum in response to allergen. Eosinophils do not appear to affect the late phase, however, in response to allergen, or the subsequent rise in airway responsiveness. So one of the authors at that time raised the question, eosinophils have limited importance in asthma. And at that same time, there was a cluster of studies that were coming out in the standard population that the FDA liked to be studied back in the late 80s, late 90s, and early 2000s, which were mild to moderate asthmatics in general, as a first testing ground for these types of drugs. And they found that there was, in fact, no change in symptoms or in lung function. And for that time, in the years that followed it, there was an abandonment of this approach to try to treat asthma. I'm going to stop there for a moment. Are there any questions about that first study? Yes.
You have a couple of studies with blood eosinophilia and then 1 or 2 that have sputum eosinophilia. Do you think that they're correlated enough that you can just look at the studies head to head?
Well, what I'm presenting you is all that exists. So can you present them head to head? Not really, because the sputum eosinophils are a far better marker for what's going on in the lung. There's a tremendous amount of variability. The fact that you saw an improvement in Dupilumab in a patient that was stratified based strictly upon blood eosinophils tells you that it may suffice as a marker, but there may be better markers. And I think that's what we're going to learn as we continue to do this kind of research over the next few years. But what's interesting to me is that, I think it was Paul O'Byrne who certainly was a huge proponent, and I think still is, that eosinophils play a role in asthma. And I think there's no question that they do, but that people began to scratch their heads and wonder, what patients would you use this drug in, if any? And this is where you start to see an emergence of studies after 2005, where it was starting to be recognized that perhaps sputum eosinophils were a marker for more severe asthma that was more likely to exacerbate. And there were experts in the field that went so far as to say if there was no sputum eosinophilia, there would not be an exacerbation. That they're in fact a prerequisite in order to see people having severe attacks of asthma. So there was a small study done in patients who had been turned to have severe eosinophilic asthma. Now, in reference to your question, these are people where it was measured in the blood. It was also measured in sputum. But these are people that we see in our practices who routinely have 10 to 15% eosinophils, where they don't have Churg-Strauss disease, they don't have allergic aspergillosis, and their primary disease process is with what appears to be difficult asthma. It was a small randomized double-blind study. You can see there were roughly 30 patients in each group of Mepolizumab, 750 milligrams, given intravenously every month versus placebo, and they treated patients for a full year. These were very severe patients. These were patients that had blood eosinophils on average of 320, sputum of eosinophils of 6%. They had doses of ICS that I haven't seen recently. You must have very large doses there in Europe. And 57% of the people were chronically treated with oral steroids. And what I think is most remarkable is that these patients had an average of 5 exacerbations per year. Now, one of the things that frequently comes up with this group is that are they not non-compliant? And I think many of them are. The data suggests that 60 to 70% of these patients are non-compliant with inhaled corticosteroids. But I have an alternative hypothesis. Rather than just non-compliance, I think they're non-compliant because in many cases the drugs don't work. This, in many cases, is a resistant phenotype. And this is what has been borne out in the phenotyping studies that have been conducted worldwide. Just check time. And in fact, that if you could enforce compliance, and I think we need to answer that question fully, which is how do we enforce compliance? How do we really get these people to use their inhaled steroids before calling them a conventional therapeutic failure? Because the cost is extraordinarily high if we call them a failure, if we start to resort to biologic agents and move away from conventional, much cheaper inhaled therapy. This adds a tremendous price tag to this particular disease. So I think we need to really look at that question again, perhaps again and again, before we give up and just say they're non-compliant or maybe they are compliant. We really don't know. And if we have any time at the end of this, I'd like to talk a bit about that. If we look then at Dr. Haldar's data, looking at exacerbations, placebo 3.4, in the active treatment group it went down to 2. Now it didn't disappear completely, but it did go down significantly. What I think is even more impressive are the fact that severe exacerbations, not just requiring steroids, but resulting in ER care and hospitalization, went down by over 70%. Days in the hospital were reduced by 75%. So when you look at this small data set, and I will say it's a small data set, the drug starts to look like it's going to have some significant effects in this subset of asthmatics. And then finally, if we look at asthma-related quality of life, there was a difference, but due to the small nature of the study, did not reach significance. Yes?
Obviously here they're using a primary outcome of exacerbation. What is it that led to the idea that eosinophilic asthma has one of the primary parts of that phenotype is frequent exacerbation? What's the biology there?
The idea that epidemiologically, in patients with more severe asthma, they found both elevated nitric oxides as well as elevated blood eosinophils. And there were studies done at that time that to titrate inhaled steroid doses to eosinophil counts in sputum or to nitric oxide as a way to find a good clinical surrogate for controlling the worst part of the disease. So there's a whole literature that precedes this study. And I think that's extremely important. I'm glad you brought that up. Yes?
Did they revisit any of the issues from the prior study? In other words, this was a much longer study looking at, again, effects on late-phase responses with the thought that maybe if you did it long enough, it might have some effect.
Yeah. In this particular paper, I don't remember there being a Kaplan-Meier curve. But certainly in this study, what you're looking at is a very different population. In the antigen challenge study, you're looking at very mild asthmatics. So it appears that at least in response to allergen, that you don't necessarily have a blockade of the physiology that follows antigen, but you do have a blocking effect on whatever happens during a severe exacerbation. And often what drives a severe exacerbation is not necessarily bronchospasm, but liquid. It's goblet cell secretions that lead to distal airway obstruction. And when people die from asthma, typically what we find in their lungs is huge amounts of fluid. So the question is it the fluid or the bronchospasm that leads to the fatal event? Many people think it's the fluid. Steve?
So this is a little philosophical, but when you look at Mepolizumab and its target is a B-cell product, right? The IgE, which is steroid insensitive, the production of that pretty much. Th2 inflammation is completely steroid sensitive in normal functioning immune system. So it seems to me there must be the niche for these drugs that would benefit beyond high-dose inhaled steroids would have to be some sort of polymorphism, combinations that are relatively insensitive to topical steroids in the lungs. And how far behind is the genetics of this at this point? Because it seems to me that what we're going after is almost probably the equivalent of separate orphan diseases for each one of these drugs that are going to have to be somehow applied to this giant disease of asthma.
Yeah, and I think it comes back again to the question of compliance. When Woodruff at UCSF looked at the IL-13 that they picked up in lung tissue, in severe patients who are on high doses inhaled steroids, about half were still overproducers. So the question becomes, is this true overproduction, most likely genetically based, or is it really non-compliance with therapy? We never answered these questions in any of our studies. We're really at a loss now to really figure that out, and I think we need to move forward with that. But assuming that they were compliant, there are genes that are polymorphisms that certainly upregulate IL-4. That's been well identified, I think, for about a decade. So what you're looking at is genetic overproduction that is not steroid sensitive. It turns out that when you look at large groups of patients, anywhere from a third to a half will have residual Th2 cytokine activity despite the use of high-dose inhaled steroids. So I think that's a little bit at odds with what we see clinically. I think we get a better response clinically, and I think the better the compliance we have, I think oftentimes the better we do. But I think there are certainly people who do overproduce, and it probably is insensitive to steroid. The exact number we don't know, and that's why these become, I think, viable drugs. The measures that were not affected in this study by Halder, and there was another study, the same issue of the New England Journal of Medicine, which was published and had similar findings. Symptoms, lung function, asthma control scores, airway hyperresponsiveness, and nitric oxide all remain statistically the same. There might have been slight directional changes, but nothing significant. So we start to get an evolving picture that this class of drugs may be important in a certain phenotype of asthma, and it may primarily treat this penchant for frequent exacerbations. The most recent study, which I think is important, is what was termed the DREAM study, again published in The Lancet this last year, which is a dose-ranging study of Mepolizumab in severe eosinophilic asthma, where they gave the 750 dose that we've already seen given, but also gave 250 and 75 and placebo over a period of about a year. A very well-powered study, over 150 patients in each of these treatment arms, more than enough to pick up changes in FEV1 if they exist. Again, very severe patients, I want to reinforce that. Blood eosinophil levels were high. Sputum eosinophil counts were certainly high, since 2% would be the normal cutoff. Oral steroids in about a third of the group. The exacerbation range was between 2.5 and close to 4. And very importantly, about a quarter of these patients have been hospitalized during the past year. If we look at the Kaplan-Meier curve, and here we're looking at the time from the start of treatment to their first exacerbation, and you can see early on a separation, which continues to be magnified. And there was not a real dose response between the 3 doses of drug. And when we put this in, I think, more understandable terms, and we look at the number of patients who did not have, this is the percentage of patients, that did not have an exacerbation, we see that in the patients that are getting placebo, it's a little bit over 30%. And in patients getting these various doses of drug, anywhere from 45 to 53%. So there was a protective effect, and if we look at it in terms of a number analysis, we look at the 3 doses of Mepolizumab across the top, and we look at FEV1, asthma control, and asthma-related quality of life, we find that there were no real changes induced by the active therapy. A little bit of a trend here, but there was so much, excuse me, let me get back here. A little bit of a trend, but certainly because of the variability in these numbers, it did not even come close to statistical significance. And this is in a sample size of 150. So we begin to have an evolving picture that Interleukin-5 plays its most important role in causing exacerbations in a certain phenotype of asthma, and that blockade of this effect may well prevent that without having other significant effects on asthma. So what can we say about anti-IL-5 in asthma? That it does reduce blood and sputum eosinophils in both the blood and the sputum. It changes exacerbations, including those from a limited data set in hospitalization, but it doesn't really affect symptoms or other patient-related outcomes. in asthma. Okay. Any comments or questions about that? Any disagreement? Do we have enough time for disagreement?
Yeah, well, it's intriguing how it would do the second thing without doing the third.
It is intriguing.
I think for those who come routinely next week, we're coming back to anti-IL-5.
Yeah.
So then we move on to GM-CSF, a cytokine that certainly has been picked up in BAL fluid. The main cellular sources are the epithelium, the smooth muscle, fibroblasts, T cells, mast cells, and eosinophils. So it's coming from a lot of different cellular sources. It's really a pleiotropic cytokine with a lot of effects. It stimulates myelopoiesis through the bloodstream, promotes leukocyte survival and activation. It modulates TLR4 and has a modulatory effect on neutrophil function. There's very little data at this point, and there is one company that's working on an antibody directed against GM-CSF by the name of Kalos Bios, who have developed a chimeric anti-GM-CSF antibody. They have a next generation, KB003, which will be humanized along the lines of 95% human. In a recent study that has only come out in abstract form and has not yet been published in a full peer-reviewed journal, I'll share with you, not to say that these data are definitive, but at least there may be an inkling of effect. There were no significant adverse effects seen in a small pilot study of, I think, around 40 patients. The mean FEV1 at endpoint with active drug did increase compared with placebo, which had a decrease. And there were reductions not only in sputum eosinophils, but in sputum neutrophils as well. And there's not much else data out there, and I think this is a cytokine inhibitor that will be worth certainly watching as it goes through further clinical development.
So what did they get, one dose of the drug? Or?
One dose, that's correct. It was given systemically. And then we turn to interleukin 17, which is produced by a whole different subtype of Th cells, which are the Th17 cells. Th17 cells make IL-17A, F, as well as interleukin 6 and TNF alpha. IL-17 is also made not only by Th17 cells, but by some T cells of the CD8 positive variety, and interestingly by T regulatory cells. So it may have some effect on regulating this whole Th2 mediated process, and there is evidence suggesting that, which we're not going to review today. The main effects are that it does recruit neutrophils into the airway. So as we hear these data, or as we start to think about the function of the cytokine, we start to think about this as a potential way to modify or modulate non-Th2 asthma. It also leads to the increase of other cytokines and chemokines, IL-1, IL-6, GM-CSF, CLCL1, CLCL2, and interleukin 8, which unto itself is a very important neutrophil chemoattractant. It promotes migration of smooth muscle cells into the airway, may have an effect, therefore, on airway remodeling, and increases goblet cell differentiation and secretion of mucus by those glands. What's interesting is that there's a balance of IL-4 and IL-17 that seems to regulate the relative numbers of these inflammatory cells in the airway. And there are asthmatics that share both of these. In other words, we try to put people into a paradigm that would have one subset be involved or one phenotype to the exclusion of others, and then this, in fact, is certainly not true because of the regulatory and counter-regulatory mechanisms that are operative in this. It's a very complex disease. And there is currently an antibody to IL-17. It is in phase 2 study. It went through a proof of concept where there seemed to be efficacy, and we're going to find out how well it actually works. I don't think the company is currently looking at whether it affects a certain phenotype, but has thrown out a very broad net to see if they can, in a post hoc way, characterize the patients that responded the best. And I think that is not without some risk, because if you end up with small numbers of patients in the phenotype that would have responded, then you end up with a negative study and no real drive to go further. And then finally, we'll end with the last cytokine, which may in fact be one of the more important, which is TSLP, thymic stromal lymphopoietin. Its principal source being the airway epithelium. We're really on the cusp of finding data looking to inhibit this particular cytokine, and it acts very, very locally. In fact, it acts so locally that it's difficult to measure levels of TSLP protein, either in nasal fluid or in lavage, in the lung. And in fact, you have to go to PCR in order to identify if there's a source for this. It's involved in responses to both microbes and allergens, particularly allergens that secrete proteases seem to have a prominent effect. I know a neighbor of yours, Steve Zeigler, has really done a huge amount of this work and continues to publish articles that really characterize the importance of this. And it's likely to be important in both sensitization to allergens, but not only that, but ongoing effector mechanisms, that being the ingress of inflammatory cells independent of IgE formation, and may therefore act as an anti-inflammatory agent if you can inhibit it. Some of the main effects are to polarize dendritic cells by upregulating OX40 on dendritic cells, which then induce Th2 lymphocytes to develop from naive cells, to augment Th2 cytokine release, which is certainly an important part of the effector mechanism of this cytokine, and then to inhibit T regulatory cell function, although there's data going both ways with this, that it may promote Treg function as well. I think at the end of the day, you're not going to know what happens in a human being, since there's a mixture of data from animal models. And currently, there is an antibody to TSLP, which just went through proof of concept, and apparently was positive enough study. They've gone on to a proof of concept in human beings. Interleukin 33 shares a lot in common with TSLP. It's an epithelial-derived cytokine, has multiple activities. It promotes CD4 differentiation into Th2 cells. So again, a very upstream acting cytokine. Recruits Th2 cells to lymph nodes and tissue for differentiation. Like TSLP, has an important effect on dendritic cell maturation and activity. And then finally stimulates mast cell cytokine production. So again, very pleiotropic in its effects. Works synergistically with TSLP. Is very hard to measure. We're trying to measure levels of this and TSLP in nasal fluid and having some difficulty. So we're taking scrapings, looking at mRNA for both of these cytokines. And there again there is a therapeutic intention for anti-IL-33, and it's currently in preclinical studies. So not enough to say about this one. We're going to touch on the last couple of, I think we have enough time to get through this. Yes?
The last two cytokines you said very specifically act locally. Has anybody looked at the first three with an inhalation therapy instead of intravenous or subcutaneous therapy?
Talking about like IL-13?
Yeah, or the anti-IL-5.
Yeah, and anti-IL-5 probably wouldn't work topically because so much of it is getting into the bloodstream. I guess if you could bind up, and I think it would be very difficult to actually bind up all the anti-IL-5 that's being produced by those Th2 cells as they're making their way into the bloodstream. But IL-13 and IL-4 are different. They do act fairly locally. And there are attempts now, there are studies that are about to begin looking at an aerosol of anti-IL-13 very directed therapy. I would personally prefer systemic therapy for those drugs simply because I think if you're trying to affect T cells in lymph nodes and a systemic switch from IgM to IgE production, that giving it locally may not be enough, but that's strictly a speculation. Now, when we get to prostaglandin D2 and their receptors, there are 3 different receptors for prostaglandin D2. We think of prostaglandin D2, we think of aspirin, but in fact, there are specific receptor blockers. CRTH2 we've heard a lot about, primarily drugs that haven't been very effective, but it's the acronym for chemotactic receptor homologous molecule expressed on Th2 cells. Thank God for acronyms. And this is probably one of the more important. It's found on Th2 cells, on eosinophils, and on basophils. And PGD2 seems to mediate both the activation and the chemotaxis of these cells in response to PGD2. And in the next slide, you'll see that really, depending on which receptor PGD2 binds to, you either get an upregulation or a downregulation. And there are 2 slides in the set that I'm going to let you look at on your own. But basically, when you look at CRTH2, it's the receptor that really promotes immune cell activation. If we look down at the bottom, we can see across a wealth of different targets, Th2 cells, eosinophils, there are changes in cytokine production and release, changes in the chemotaxis of eosinophils, changes in the degranulation of basophils, as well as with both dendritic cells and mast cells. And if you look at the other receptor, the classic PGD2 receptor, which is termed DP, and you can see that the cellular mechanisms for how these receptors activate and make their way into the nucleus, the DP has the opposite effect. It really tends to inhibit immune cell function rather than promoting it. So therefore, you can't really just do a non-specific approach. You really want to target on the receptor that mediates activation, and that would in fact be the CRTH2, which is why this has garnered so much attention. This is another cartoon showing some of the effects. There have been approximately 7 to 8 different molecules that have gone into early phase development trying to inhibit CRTH2. Most of these studies have focused on very mild asthmatics. People, in fact, who are not only not inhaled steroid users, but are strictly using beta agonists for control of their asthma. At least 3 of these showed no significant improvements. Many of these never released their data to the public, so I can only imagine that they were negative studies. The most recent, which did release data, is a company, Array Biopharma, conducted a study of their molecule, which was an anti-CRTH2, for 4 weeks in a fairly good-sized group of patients, 184, who had mild to moderate allergic asthma. And these patients were stratified on the basis of nitric oxide. So this becomes a very important distinction between the approach to the development of this drug to its predecessors and other drugs that are targeting this particular molecule. For the entire study population, they saw a 3.9% improvement in FEV, which is certainly the best that's been done to date, and was statistically significant. But when you focus on the patients that had an elevated nitric oxide, and I believe they used a value in the high 20s or 30, that close to doubles the magnitude, which again was statistically significant, and I think allows us to see that the approach really has to fit the right subtype of patient, and the oversight in not doing that will potentially lead to a therapeutic failure. Other endpoints which did improve significantly, and we do not yet have a peer-reviewed paper from this, are short-acting beta agonists used, asthma control, symptom-free days, and quality of life. And exacerbations in this relatively small, mild group favored the active compound, but I think all of this is far too preliminary to make virtually any conclusions, but it certainly is a good first step towards developing a new approach to asthma. The reason I think this is important is really shown in the next slide, which is when you look at the level of PGD2 in bronchial fluid, and this is a paper from Sally Wenzel just published. We look at healthy patients on the left, mild patients with no ICS, mild to moderate with ICS, and then severe patients. We see a stepward increase, but particularly in the more severe patients, a much higher level of PGD2. And I think that what we're going to have to do once again is not make the mistake that was made by Immunex a decade ago, but to shift the attention of this particular approach to patients who have elevated eosinophils, nitric oxide, or potentially periostin, and look at the effect of these inhibitors in that group. Steve.
Did she explain what the difference was with the more than that were no different in the severe group compared to the ones that were way up?
It's very heterogeneous.
I know.
It's very heterogeneous.
It would be nice to know how to identify them.
And that's what we don't know. Short of getting bronchial fluid, which is probably not a good way to evaluate an asthmatic. We don't, but I think there will be markers developing. The question is, can you get it out of sputum? Could you get it out of an exhaled breath condensate? I think these are the questions that now show us another potential target population. Yes?
Am I wrong in assuming that just taking a non-steroidal would prevent the production of PGD2?
No, because it's non-specific. In other words, PGD2 has some good effects and it has some bad effects. What you really want to do is block the receptor that's mediating the, otherwise you're going to hit both sides of it. So with a non-specific approach, as we've seen with other drugs, you really want to target the receptor that promotes these immune activating effects.
Bad part.
Exactly. About to lose my voice. We may stop short of our very last drug, if you'd like, or I can finish. But in summary of these agents, I think that they are theoretically attractive, and I think there's something to watch. As we go into development, I think we're going to have to focus again on what we think may be the right phenotype. I think starting with more severe patients is a good starting point, and then potentially identifying patients who are really PGD2 overproducers. I have a couple slides on toll-like receptor 9 agonists. If you like, I can go ahead and complete. The basis of the therapy is to stimulate these innate immune system receptors, these toll-like receptors, particularly TLR9, that in fact recognize pathogen-associated molecular patterns, things that the immune system recognizes in bacteria. And thereby allowing the immune system, with the recognition of this DNA, to shift from Th2 production and shift over to Th1. So it's, I think, a very simple algorithm that we're starting with. QBG10 is a nanoparticle. It's a virus-like, non-infectious nanoparticle that has recently been used to wrap around a core of DNA. So we've got a protein code from the bacteriophage that's filled with this DNA oligomer called G10, which is a CpG motif. Similar to what we've seen in the past, with the exception that we now have a protective mechanism around the DNA that we're trying to deliver to the local bronchial immune system. This is produced by cytos. And what's thought is that when you have this protein shell surrounding the DNA, you don't get instantaneous degradation, which was one of the largest criticisms of the old approach. What does the CpG actually do? To simplify it, I think grossly, it induces these dendritic cells, particularly the plasmacytoid dendritic cells, to make interferon alpha, and it induces the production of T regulatory cells. So I think if you were to name two of the important activities, it would be on antigen presentation and on the production of these T cells that downregulate Ig production and allergic inflammation. In their proof of concept, and this is something, again, that has been shown not only in abstract form, that what was published in JACI going back to last year. I don't know if any of you saw this article, but I think it's an important thing to look at. Stable patients who were randomized to this therapy or to placebo. They were inhaled steroid users, but FEV1s were extremely good. NO was on the low side, and patients had complete asthma control. And if we look down across this 12-week study, we find that they were at 100% of beclomethasone dose initially over the first month. They cut it in half, and then finally they eliminated it completely. An approach very similar to what was taken by Sanofi. And if we look at the graphics presented in the article in Journal of Allergy, we're looking at the change in asthma symptom scores, the change in asthma control questionnaire, and the change in FEV1. And all of these comparisons, at least for many of the time points, reached statistical significance. So that we see in the patients who actually receive placebo, because you withdraw steroids, FEV1 goes down, and the FEV1 is maintained in the patients getting active therapy. In a recent abstract that was, God bless you, that was recently shown, too much IL-13. In a recent abstract that was shown at the European Respiratory meeting, ERS, they demonstrated that the effect was magnified in patients who had elevated blood eosinophilia. So again, a reinforcement of this story that is now becoming all too familiar, that if you have a Th2-mediated therapy, and if possible, you'd like to focus on patients who seem to have this residual, persistent Th2 effect with increases in IL-4, 5, and 13. And if you look at the patients who had well-controlled asthma, as we go through this 12-week study, we find at the later time points that close to about 3/4 of the patients on therapy coming off of inhaled steroids had well-controlled asthma. What's interesting to me is that about 1/3 to 40% of the patients on placebo coming off of all therapy also had well-controlled asthma. So this may have been an exceptionally mild population, and I think we're going to have to see results as this particular approach moves into a more severe group. So the summary of the TLR9 agonist is that it is very novel. It's a reinvention of an older approach to treatment, working through mechanisms of action that we don't fully understand. And I can tell you that it is currently in studies of more severe patients.
Why TLR9 as opposed to a different, why 9 specifically with TLR9?
TLR9 seems to be that part of the receptors that has the biggest effect on promoting Th1 development or Th2 development. The Th1, Th2 balance.
Is it normally recognized?
Is it normally recognized?
What is its normal recognition? What is it normally recognized as a receptor?
To deal with infectious particles. anti-allergens to some extent. So, what's that? Yeah, infections, but allergens as well.
Is it just DNA? Is it just DNA, or is it RNA?
DNA wrapped in protein.
It's just DNA.
Just DNA.
Not RNA.
Yeah. So if we look over what we've covered today, that there are a number of these cytokines that have been targeted for inhibition, starting with IL-13 and IL-4, but moving on through anti-IL-5, CRTH2, and TLR9 agonists. I think will all have utility probably in patients that have Th2 asthma. Anti-TSLP and anti-IL-17 may be something that we're looking for with respect to patients who don't fit into this Th2 subtype. The real question becomes how much non-Th2 asthma is there? And I'm not convinced that there's all that much. I mean, certainly we have the obesity variety where many of those people don't have asthma at all, but in those patients we find very low nitric oxides. But in most of the other phenotypes that have been identified through phenotyping studies, 3 of the 4 are allergic with eosinophils. 1 of them is non-allergic with large amounts of eosinophils. And it's that last category they call type 3 or the obese non-eosinophilic asthma where approaches like anti-TSLP or anti-IL-17 may potentially play a role in them as well. So I'd like to thank you for your attention. We got through a lot of cytokines today. And if there's any questions, be glad to answer.
Thanks, that was absolutely brilliant. If there are no questions, we'll just take a momentary break and present a case, and we got to get you to the airport in time for the flight.
Hey, what's the key word? Cytokines. Good. Did you say that? Were you not paying attention? Were you not paying attention?
I wasn't.
It's on the screen.
I saw, and I saw that on the first slide.
Mike, see you next week. Hopefully we get this case for sometime this year. No, my day off switched to Friday. So I'm probably going to be able to start 2 Fridays a month. I have to take calls and like that. One hour weekend. You just have to pick.
They're still looking.
Well, I think, okay, so actually not specifically, but is it open?
Yeah, exactly.
Well, yeah. They don't have that money.
That's an interesting thing. I mean, sort of like, so many guys.
I'm kidding that one.
Because usually it'll be January for June. You're talking about 2000. I thought you stopped before.
Very obvious. Anyways, right of the spectrum. Yeah, that's correct.
That's true.
But if they tell you that the overlap
No.
He's 12, back 2 months later. They need one of
Small studies.
Very interesting. It's a lot. Yeah, it's labs. Louisiana, I'm here. I was like, anywhere over there now.
Right now?
I missed the.
I would
Yeah.
Was that, I forget what kind of approach we said.
Thank you.
And when they went back and did an analysis with more severe patients, they found that it worked. They just set out to, I think they had a checklist of drugs they had to get through.
That's kind of crazy because in their office, they stop the problem.
They've got anti-TSLP, they're putting a lot. I talked to Paul over it.
What do they want?
They did it in an antigen challenge model. All these others.
Pass me a note, right? You got yours. Especially after that, you can.
It is. I think it's more how much of it will get to the clinic.
Oh, really? Oh, is that right?
And they didn't want you to feel left out.
Yeah. Well, there's
I was just telling you. I'm gonna scoop you.
I know, I'm a farm.
Yeah. And
You're right.
there won't always Indiana, right? That's where I'm from, so there's a lot of us there. But I wouldn't think that everybody would kill it down there, though.
Thanks for
No, that's grandparents. Well, yeah, no, and I just.
Do you really? You're like,
I don't need that.
I'm
retired.
I was a kid. Everybody wants me to.
Yeah.
Well, I thought you were in Florida.
Was there was a guy,
football player.
I was thinking about here.
For the Seahawks years ago.
Yeah, let's negotiate your contact now.
Yeah, you know, they were saying, hey, are you guys...
Let's go ahead and sit down. We don't have a lot of time.
Yeah, but it's still.
This is who I'm supposed to be.
And then we're not working on it.
Yes.
This guy. Yeah, just pick up, that's what I'm supposed to be.
I know there's meant to be one of
No, I'm kidding. I wouldn't be surprised.
I gotta go find out.
Alright, that's good.
No, I've been away since 87, so...
I got the hair. I got a hair.
I gotta run it.
Anyway, take care of yourself.
Yeah. Oh, shut up. It's good to see you. Yeah, I'll be hanging out.
When do you want us to try to be done by 8:30?
What do you feel comfortable leaving to get to the airport?
Corren and I.
Okay. We got a driver and a car right outside, so we're ready to go.
Don't stop on my account.
The case is nothing too, it's not meant to be a mystery or anything too tricky, but just a sort of dilemma in treatment. This is a guy that Bill swapped out, and a couple of us have seen and taken care of at the U. And I'll just run through it. He's 56, he's from Cambodia, and like see a lot of stories like this, came to the U.S. and developed asthma, although it was pretty delayed. So he came in 85 when he was, 20 or something, 20s. And in about 2005, when he first came to clinical attention, he may have had symptoms before that, was what at that time was fairly mild persistent asthma, treated with a low-dose inhaled corticosteroid and albuterol. Things changed in, as far as I can tell, early 2011, and looking through his records, it seems to be due to an infection. So he had this fairly severe exacerbation in January of 2011 in the setting of what they thought was a lower respiratory, an upper respiratory, lower tract respiratory infection, the right upper lobe. They actually initially thought he had TB, which was eventually ruled out. He was hospitalized for a while on quite a bit of steroids, and he never got back to his baseline after that. So over the next 8 to 12 months, his medication sort of persistently went up. First, just increasing doses of inhaled steroids, montelukast was added, and he was on a combination inhaler, and even had theophylline added along the way there. Despite all of that, he was in the ER every month or two for a fairly severe exacerbation. He was admitted, maybe a third of those times, and was on frequent courses of prednisone. Was also sort of on what eventually became chronic prednisone for a while. There's nothing too concerning in his social history other than what I have already told you. So he never smoked. He doesn't have pets. He was working as a forklift driver in a warehouse, maybe some sort of inhalational exposure there, but it was nothing too out of the ordinary. And for the last year, because of the severity of his asthma, he's been unable to work. He doesn't identify any clear triggers. It is, however, quite clear that respiratory infections trigger him. This is just a slide I've recycled. You know, whenever I see a patient like this, I kind of step back, think outside the box, expand the workup. David actually started this, and really there was nothing else too profound that we found that came to attention, and I'll just run through some of that. So first off, just to look at his spirometry, sorry, these are pretty small, but clearly fairly obstructed, and the numbers, you know, an FEV1 down around 57%. He does have a reasonable response to bronchodilators. You know, we always get additional workup in these sorts of settings, so nothing too profound in his lung volumes, and very importantly, a normal DLCO. Maybe some evidence of air trapping here from his lung volumes. Interesting thing on a CT, so this is just a mid-level cut of his lungs, quite normal. He has, however, had quite profound bronchiectasis, although only in one area, in the left lower lung. This was first picked up when he was hospitalized in 2011, and on a repeat image that we got 2 years later, appears relatively unchanged, and there's no evidence of sort of chronic infection down there, but it's something that I worry about a little bit in a guy like this.
Did the radiologist call it central or more distal?
They didn't comment on that. Looking at it myself, I would call it more central, and not really in the distal and the peripheral. His other workup, so again, all those other things on my differential that I threw up there were effectively ruled out. We had a normal cardiac workup. Sinus CT was not too revealing, a little bit of mucosal thickening. On his lab workup, one thing that I noticed and was hopeful we might be able to treat was he did have, he's had quite a bit of eosinophilia, often up around 700, 800, 1,000. However, when I saw him back after an initial visit in our clinic, he was down in a more normal range, 300 to 400. And notably, when he is on steroids, these are suppressed effectively to zero. But certainly raising the idea that this is eosinophilic in nature. He does have a reasonable IgE, again, sort of a Th2. We got a fairly extensive immune workup that was normal, a rheumatologic workup that was normal. Strongyloides was ruled out given where he's from, but he does travel back to Cambodia. Negative TB, look for alpha-1 antitrypsin, ABPA. And then, you know, looking for an allergic cause. So RAS was negative on skin testing. We were able to sort of force him to have a positive test after a bunch of intradermals. He was positive for one on dust mite with the idea that we try him on Xolair. So that's sort of the extent of the workup. Notably, we don't have a NO, an FeNO. And his vitamin D was very low for what that's worth. So we did start him on Xolair based on his IgE and the positive skin test and the fact that we had very little else to do. He doesn't think there was any response. I would tend to agree with him. That said, when we started it, he was on some chronic steroids which have tapered down, but sort of gone on and off of that, and he has had exacerbation while on Xolair. He has been very aggressively treated for GERD, which I'm sure he has, including eradication of H. pylori, which is certainly bad. And then I put this up there, although I'm not sure this is true. You know, we often talk about in these sort of severe asthmatics, especially where there's some underlying ectasis or damage to lung parenchyma. He has gotten short courses of both macrolides and doxycycline, but he hasn't had a more long-term treatment. And, you know, with this, he's having still quite frequent exacerbations and unable to work. So I guess questions as to what anybody in this room thinks might be going on, what else we might do. We are using Mepolizumab at the UW through GSK's compassionate use. I was hoping to try to enroll him on that, but then its EOs dropped down to 300. So that's going to be difficult to swing on it to do it. So not meant to be a diagnostic dilemma, but if there's any other workup you would do.
When he gets these infections, do they present clinically more like sinusitis or more like a lower respiratory?
Well, a lot of his exacerbations, I think, I haven't seen it for all of them, but a lot of his exacerbations, I think, are not infection related.
Are not infection
Are not infection related.
Why do you say that?
Well, he doesn't have any prodrome of an infection. It just sort of comes out of nowhere. He may be. He's not getting sort of viral swabs and viral PCR is done every time this happens, and I don't think he's getting an infection every month. And again, when he does get antibiotics, I don't think they do anything. I would say it's difficult to communicate with him because of a language barrier. I think when he does get an infection, it's mostly upper respiratory, so just a sort of viral URI. That's definitely the trigger. I don't think he's had recurrent lower respiratory infections. There's been no evidence for recurrent pneumonia or bronchitis.
The only reason I ask is because of the bronchiectasis that's localized rather than diffuse.
Right.
And something changed his asthma at a discrete time point.
Yeah.
You know, it's interesting when you go back to Jim Good's stuff from National Jewish, where he published on close to about 60 people who had severe refractory asthma. And when they bronch these people, around 20 to 25%, they couldn't find actual culture positivity for chlamydia, pneumonia, or mycoplasma, but PCR was positive, and I called him about this. And it turned out that he said sputum induction will probably not work. And I talked to Richard Martin about this, who's at National Jewish. They think you have to get tissue. And that these people do get like a mycoplasmal infection, and it changes their asthma.
Right.
And they keep getting reactivation because it's hiding in the tissue, which those bugs like to do.
Yeah.
They're sort of protected, and they're living intracellularly. And that it may be worthwhile, because if you're going to commit them to probably 3 months of therapy minimum, you really want to know. The other thing, did you do IDs or prick?
Both. And so he was only positive on that one ID.
Did you ID him to Aspergillus?
I think we did.
Usually,
I'm not sure.
I don't think we did.
Usually we don't ID the molds here. In this context, you might. Usually we just think you get false positive reactions.
I agree with you completely. But there was a paper. It was called the FAST study, published in 2008 in the American Journal of Respiratory and Critical Care Medicine, and they took people who had positive skin tests, prick, and I'm not sure if they went as far as ID. The Europeans generally just do prick or some kind of an IG ELISA, but they were positive with or without positive colonizing organisms. They put them on itraconazole for 3 months. And the approach was that they think that many of these people are colonized even if you don't detect it. And if they're hypersensitive to something that they're very well colonized to. And they just looked to see what would happen. So all they had to be was skin test positive to some common mold. And I'll get you the paper, I can email it to you. But it was fascinating because these people got better. But it took 3 months of therapy. But they did have evidence, because I'm looking at that IG of 300. We see this all the time. It's like polyclonal IgE to what? It's probably not all directed to might. So one of the explanations is that maybe in those patients it is warranted to go on and do an intradermal. I don't think we know.
So when you say his ABPA workup was negative, you mean the skin test was negative?
Yeah, his skin
did serology as well.
We did an IgG and an IgE.
And they were negative. Have you cultured his sputum yet to see both the fungus and bacteria?
He just had routine sputum cultures when he's hospitalized, but we've not done anything. I know it's been negative, but we've not done anything more extensive than that.
I want to
it's a long shot, but
a therapy that maybe younger people here have long forgotten that really came out of Seattle. Now, if he's got a hidden infection, this might be the wrong idea, but methotrexate, this is decades ago that Mike Malarkey, our colleague here in Seattle, first promoted it, and it had a good half dozen peer-reviewed studies, almost all of which were positive, showing a steroid-sparing effect. And based on almost no data, you've probably seen me use cyclosporin in these people. And thinking about everything you said this morning about these complex, esoteric T-cell-directed drugs, cyclosporin is cheap and generic and actually targets T cells, and at least anecdotally, for me, has worked dramatically in some of these recalcitrant patients.
Yeah, I don't know that this guy is steroid dependent. as I was reviewing the case last night, it was more, he has not had a lot of bad side effects from the steroid use, and he's off of it a lot. He is on a lot of inhaled steroid, but it's really the inability to work the frequency of the exacerbations that is, compromising.
We need some therapy to make it better.
Yeah.
How about a bronchoscopy to swash that?
Well, I think that's a reasonable idea. We're working with pulmonary, and again, as I was looking through this last night, and that bronchiectasis came to my attention, I was thinking, well, either just empiric antibiotics, or maybe we should go ahead and try to get it better. So when you say a biopsy, how do you?
Transbronchial biopsy.
Yeah, I don't know.
And then they actually process it for PCR, which is expensive because I've looked into it.
Yeah.
You're looking at $300 to $400, but in this case, cheap. It's a lot cheaper than 1 month of Zola.
Yeah.
So
I have to ask the pulmonologist if they can get to that part of this long. Again, I think it is central, but not sure.
Or anything that may look infected, where there's secretions. But I often wonder about these people that have these. I've been thinking about this for years. High IgEs with almost negative skin tests, or one allergen, a 1+ reaction to mite. They got an IG of 250. And you look over the Mepolizumab data, and some of those people only were sensitive to one thing, and they had IgEs well elevated above normal. We haven't really dealt with that phenomenon too much. I think some of it's fungus. I just have this feeling, looking back at the FAST data from Europe. And I think some of it is this new emerging idea that, particularly in polyp patients, which he doesn't have, that they've got colonization with Staph aureus, and that they're making IgE to Staph aureus enterotoxin A, which is, Klaus Bachert's, basically all his work. And I think that you haven't, so what I'm now doing is immunocapping to Staph aureus enterotoxin A. There's a commercial assay for that. To the E to that particular target. And we get it through Kaiser. Bruce Goldberg does it down in LA. But I think Thermo Fisher has it commercially available. And I think we should start looking at that. We're not doing it yet. There's no skin test for it. But I think that's something that we should do. I agree with you completely, though, about I use Cellcept, which is basically like using cyclosporin. Very similar drug.
And I've compared the two. This is just empiric, anecdotal medicine. I can't quote anything. Cyclosporin, for me, works better.
Mm-hmm. I think it's a stronger drug.
Yes.
A few more side effects, though.
It's amazing. Compared to steroids, there's no comparison. It's a much safer drug. Long term, you just monitor it.
Okay, so I guess we'll try to figure out if he has an infection, whether it's been a chronic infection all this time, or if he has some immune activation.
Is he a staph carrier in his nose? Do we know? Yeah. Might want to culture him during an infection, just to see.
I take it that you really were cheating with his dust mite. You had to get him on Xolair. He really is not atopic at all.
No, it's not.
Or marginally, right?
Except an elevated IgE.
I mean, I do that as well. You have to get somehow off the skin test. You just overread it. Yeah.
Why do you think that the IgE has to be specific against something? I mean, if you have a Th2 inflammation, then obviously you'll get some IgG shifting toward IgE. And it doesn't have to be specific against anything. It's just a marker for Th2 inflammation.
I think that to make that assumption without considering the possibility, I think, to me, seems nihilistic. In other words, you're right. It may be against nothing, but it may be against something. When you look at the CIU patients in the study that was published in New England Journal of Medicine, they are non-atopic, and they have an IG of 120, I think, was the average, well above the average person off the street. And those people had no rhinitis or asthma. So I think it at least raises the question, is there a hidden allergen? And I think with Bachert's work, it tells us not to be nihilistic. It turns out that they do have polyclonal IgE in some of the patients. In some of the patients, it's not polyclonal. In some of them, they don't respond to any of the normal airborne allergens, but then they do have IgE to the staph, which could be the sole target for a lot of us. I think you're absolutely right. A lot of it may just be to whatever, and we're not picking it up. But I think that to make that concession early in evaluating this patient, I think we should probably look further. Is my gut feeling.
Makes me think of the people with who we start to think who have local IgE production, both in what we classically call intrinsic rhinitis or eosinophilic non-allergic rhinitis or intrinsic asthma, that they have specific local IgE production, and they may have some non-specific total serum IgE, but we don't know what they're reacting to.
They're like the other side of the coin.
Yeah.
So they're atopic with no evidence, and these people have evidence but appear not to be atopic. But and that's interesting because in these people that have polyp disease and IgE to staph, when they have polyp alone, they pick it up only locally and not in the blood or skin. I don't think they're doing skin, just blood. And once they develop systemic evidence of IgE to the staph, most of these patients then have asthma. So it's almost like watching the atopic march in a human being. That goes from local disease with local IgE, and as it becomes systemic IgE, they develop more distal manifestations away from the nose. So I think that really warrants a lot of attention, some of that stuff that he's doing. It's very interesting.
Thanks very much for coming. Good morning.
Thank you.
We got to get to work. We got to get home.
Yeah.
All right. Great.
Thanks.
Glad Steve got here to say hi. I'm glad Steve got over here to say hi.
Oh,
He had to go to work.
yeah.